Hello, I'm Dr. Sam Johnston. I'm a clinical cardiac electrophysiologist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. Today I'll be speaking to you about the ECG in sudden cardiac death. I have no disclosures that are relevant to this talk. Identifying patients at risk for sudden cardiac death is a priority because it's a major cause of death worldwide, especially in industrialized nations, and we have effective means of treating it, namely the ICD. The optimal risk stratification tool would be non-invasive and inexpensive, simple, widely available, and effectively predictive. Individually, none of the tests that I've listed here is broadly predictive in a large population, but the 12-lead ECG remains an attractive screening tool because it's low cost, non-invasive, and widely available. It can effectively identify patients with arrhythmias and ischemia. So the good old ECG, as we recognize it today, is 120 years old, and it's still an important tool in our risk stratification of patients with sudden cardiac death. I've divided this talk into two parts. The first part is the ECG deconstructed. Here we'll focus first on the QRS interval, and then we'll focus on the QT interval. Afterwards, we'll move on to the second part of the talk, which is ECG findings that are unique to diseases that cause sudden cardiac death. And I've divided sudden cardiac death into two broad groups. Sudden cardiac death in apparently structurally normal hearts, which I've called electrical. These represent the minority of cases of sudden cardiac death and probably only 5 to 10% of cases. The other group I've called structural, and they represent the vast majority of cases of sudden cardiac death. We'll start by talking about the impact of the QRS duration on one's risk for sudden cardiac death. Both the right bundle branch block and left bundle branch block are strongly correlated with the presence of underlying heart disease. Both right and left bundle branch block are present in less than 1% of the population, and the prevalence of both increases with age. The Framingham study showed us that 70% of patients with a right bundle branch block already had at least one cardiovascular abnormality that had been identified. But interestingly, cardiovascular mortality in the right bundle branch group was 3 times greater than in age-matched persons without right bundle branch block. Similarly, the Framingham study showed that those with left bundle branch block are at increased risk of death. In fact, 50% of patients died from cardiovascular disease within 10 years after left bundle branch block was diagnosed. But other studies have suggested that increased mortality in right and left bundle branch block may be due to the development of other organic heart disease, not the conduction defect per se. In patients with left bundle branch block, sudden cardiac death is more often due to ventricular fibrillation rather than heart block. The data on the impact of QRS duration on sudden cardiac death are conflicting. Here I've listed 2 studies that sort of illustrate that point. The first one is called QRS duration predicts sudden cardiac death in hypertensive patients undergoing intensive medical therapy. The second patient is QRS duration does not predict occurrence of ventricular tachyarrhythmias in patients with implantable cardioverter defibrillators. So the take-home points here are the data are conflicting, but we know that mortality is higher in those with wider QRS intervals. However, that mortality may be related to the development of other organic heart disease, not the conduction defect per se. We're still focusing on the QRS interval, but now we'll turn our attention to QRS fragmentation. Some prior studies, including cardiac MRI studies, have shown a strong correlation between QRS fragmentation and myocardial fibrosis, scarring, and aneurysm. Das and colleagues at the University of Indiana noted that in the past couple of decades there had been a dramatic decrease in the instance of Q-wave MI and a reciprocal increase in the instance of non-Q-wave MI. Additionally, they noted that Q waves regress or disappear in a lot of patients who've had an ST elevation MI. So the sensitivity of Q waves for old MI is low. The Indiana University group had previously shown that in the absence of bundle branch block, fractionated QRS of various RSR prime patterns has a higher sensitivity for prior MI than Q waves. So they hypothesized that cardiovascular event rates would be higher in patients with fragmented QRS complexes. They retrospectively analyzed more than 1,000 patients in their VA hospital, and as we just discussed, it was already known that bundle branch blocks are associated with higher overall mortality rates. Therefore, they excluded all patients with typical right bundle and left bundle branch block with QRSs over 120, as well as patients with incomplete right bundle branch block and a QRS duration between 100 and 120 milliseconds. Then they categorized different fragmented QRS morphologies into 6 different categories, which I've shown here. This sequence of ECGs demonstrates QRS fragmentation in a patient who suffered an inferior wall infarct. Notice that 3 months post-infarct, the inferior lead Q waves are pretty unremarkable, but that the fractionation in the QRS complex is pretty easy to see. As you can see in these Kaplan-Meier curves, the difference in cardiac events among patients with a fragmented QRS versus those without is striking from the onset. This is shown in the left graph. Likewise, in the right graph, you can see that all-cause mortality was significantly higher in the fragmented QRS group, and the curves had separated by about 3 years. Interestingly, there was no statistically significant difference in event-free survival for either cardiac events or all-cause mortality when comparing patients with a fragmented QRS with patients with pathological Q waves. But recall that fragmented QRS is more sensitive than pathological Q waves. It's also worth noting that a sub-analysis of the SCUD-HEF trial demonstrated that an increased fragmented QRS correlated with an increased incidence of ventricular arrhythmias. Now we'll move on to discussing the QT interval. There are a lot of data about ischemic changes in the ECG and survival. And when combined with other variables, ECG ST segment changes are highly predictive of short-term and long-term mortality, including sudden death. So these data are familiar to most of us and we won't dwell on it. We've already briefly discussed that the residual impact of ST elevation changes, namely pathological Q waves, are predictive of long-term sudden cardiac death, but that they're less sensitive of a finding than QRS fragmentation. Let's talk about early repolarization. For a long time, early repolarization was considered a normal variant, and in the past 15 years or so, it's been correlated with sudden cardiac death. Early repolarization is defined as elevation of the J point by 0.1 millivolt in 2 contiguous inferior or lateral leads, where the J point is defined as the junction of the QRS complex and the ST segment. Patients who have early repolarization on their ECG are at an increased risk of idiopathic ventricular fibrillation. And early repolarization may have an inherited component. Early repolarization is common. In this study of more than 10,000 patients, it was present in almost 6% of them. Some gene mutations have been implicated in early repolarization, such as L-type calcium channel subunits, the ATP-dependent potassium channel, and SCN5A. The figure on the right here shows examples of J-point elevation in 2 different patients. The same study showed that more J-point elevation confers more risk. However, early repolarization as a risk factor for sudden cardiac death isn't that straightforward. In fact, it seems to be a normal variant in some people and to confer risk in others. So, for example, a lot of young black males meet criteria for early repolarization, but they don't necessarily have increased risk of sudden cardiac death. Now we'll change our focus to the QT interval. This is a case from my colleague, Dr. Barry London. This is a 51-year-old man who had a cardiac arrest while shopping. Subsequently, he was shown to have normal coronary arteries by an angiogram and no structural heart disease on an echo. His family history was notable for first-degree relatives dying in their 40s and 50s of heart attack, and I think he also had a brother who drowned at age 13. Look carefully at this ECG. At first glance, it's not all that remarkable, and if it were sitting in my bin of 100 ECGs to read for the day, I don't think it would really grab my attention. If we look carefully at this ECG, you'll see that the patient was slightly bradycardic and his uncorrected QT interval is 450 milliseconds, but his corrected QT interval is normal at 433 milliseconds. Ultimately, this patient and his family members were shown to have a long QT type 1 mutation. A line tangential to the descending slope of the T wave where it crosses the baseline correctly measures the QT interval. A corrected QT interval of greater than 440 milliseconds is abnormal for men, and a QTC of greater than 450 milliseconds is abnormal in women. If we use a cutoff of 480 milliseconds for the corrected QT interval, then that increases the specificity for long QT syndrome. But as we can see in this patient that I just showed you, he would not have met these criteria for a long QT. And that's reflective of the dynamic nature of the QT interval. The QT interval is typically measured in lead 2 or lead B5, and if a U wave is present, it's not included if it's separate from the T wave. Clinical manifestations of a long QT interval include, of course, torsade de pointes, which is shown in the top figure, and less commonly macroscopic T-wave alternans, which is shown in the bottom figure. Note in the bottom figure that the T waves are marked with asterisks, and you can see how they undulate from beat to beat. This sort of macroscopic T-wave alternans is a harbinger of polymorphic VT and cardiac arrest. Here are the ECG patterns in the most common forms of long QT syndrome. In long QT syndrome 1, the QT interval is long, but otherwise it has normal proportions. Also, if the patient is standing up or exercising, there's a paradoxical lengthening of the QT interval as opposed to a shortening of the QT interval, which is what you would expect in a normal patient. In long QT syndrome type 2, there's a bifid or notched low amplitude T wave. And in long QT 3, there's a long isoelectric ST segment, as illustrated here on the bottom. Acquired long QT syndrome is far more common than inherited monogenic forms of long QT syndrome. An acquired long QT syndrome can be caused by a number of different drugs, some electrolyte abnormalities, ischemia, and intracranial hemorrhage. It's thought to be due mostly to binding of drugs to the KCNH2 gene product, or hERG, and unlike the other inherited forms of long QT syndrome, acquired long QT syndrome probably has a polygenic vulnerability. This is an EKG from a 35-year-old female at our hospital who is on psychiatric meds, who had a normal potassium and a normal magnesium, and you can see that she has a very long QT interval. This is a patient who had recurrent syncope after starting Multac or dronedarone for atrial fibrillation, and this is an example of drug-induced long QT syndrome. and also some short runs of torsade de pointes. This is another patient with acquired long QT syndrome who was taking fluconazole, levofloxacin, and metronidazole and had hypokalemia with potassium of 2.9. This is the same patient off of those medicines with a corrected potassium. And you can see that also this patient's QT interval has normalized. There is also a short QT syndrome, and this is pretty rare, but a short QT interval is defined as less than 360 corrected in men and less than 370 corrected in women. However, most cases that have been described show that these patients have an even shorter QT interval, and you can see that illustrated here in this ECG. These patients are particularly susceptible to atrial fibrillation and ventricular fibrillation. However, a short QT interval alone doesn't necessarily predict risk of sudden cardiac death, so a scoring system has been developed which also includes clinical history, family history, and genotype. Now let's move on and look at some cases from patients with diseases that we haven't talked about already. Here you see the classic pseudo right bundle branch block with a coved ST segment elevation in leads V1 and V2. Patients with Brugada syndrome tend to have sudden cardiac death due to ventricular fibrillation that occurs at night or when they're at rest. It's about 9 times more common in men than women, especially some people of Southeast Asian descent. About 20% of cases are due to a mutation in the SCN5A gene, but it's estimated that the majority of cases are probably a polygenic disease. Classic ECG findings in the Brugada syndrome include a pseudo right bundle branch block and persistent ST segment elevation in V1 and V2 with the following patterns. The classic type 1 or coved pattern is probably the more clinically relevant phenotype and a higher risk phenotype, and it's defined as an elevated ST segment of more than 2 millimeters that descends with an upward convexity to an inverted T wave. The type 2 or saddleback pattern is an elevated ST segment that descends towards the baseline but then rises again to an upright or biphasic T wave. These findings are dynamic, so the patient may only intermittently meet the criteria. Putting the ECG leads higher, like 1 or 2 rib spaces higher, may increase the sensitivity for detecting Brugada syndrome. The phenotype is more obvious in patients who have a fever, and the phenotype can be unmasked in some patients by giving them a sodium channel blocker, like flecainide, procainamide, or ashmeline. Catecholaminergic polymorphic VT, or CPVT, is a polymorphic VT that is, in most cases, autosomal dominant and caused by mutations in the ryanodine release channel, or RYR2 gene. Less commonly, it can be an autosomal recessive disease and caused by mutations in the calsequestrin gene. But in any case, patients with CPVT generally have a normal ECG at rest, such as in this patient. But with exercise, they tend to develop ventricular tachycardia, which is often bidirectional, as shown here. Moving on to arrhythmogenic right ventricular cardiomyopathy, or ARVC. This is a patient with ARVC, and he has some classic ECG findings. We'll come back to them in just a moment. There's some debate as to how sensitive the ECG is for detecting arrhythmogenic right ventricular cardiomyopathy. One large study, which I've cited here, showed that 85% of patients with ARVC had an abnormal ECG. However, 2 earlier studies showed that up to 40 to 50% of patients with ARVC actually had a normal ECG at baseline. I think the take-home message is that ARVC is a progressive disease and that given enough time, most patients will develop the phenotype on their ECG. We still use the 2010 revised task force criteria for the diagnosis of ARVC, and within these criteria are 6 diagnostic categories. 3 of these categories are ECG abnormalities, including repolarization abnormalities, depolarization abnormalities, and arrhythmias. This ECG shows the classic repolarization abnormalities, which are inverted T waves in the right precordial leads V1 through V3. This ECG shows the classic depolarization abnormality, which is the epsilon wave. You can see that illustrated in this ECG. There's a red arrow pointing to it. The epsilon wave is usually seen in leads V1 through V3. Now back to our patient with ARVC. You can see in his ECG that I've highlighted the repolarization abnormalities with the red arrows, and I've highlighted his epsilon waves with the blue arrows. Now let's move on to hypertrophic cardiomyopathy. This is a patient with hypertrophic cardiomyopathy, and his ECG here demonstrates some of the classic findings. We'll come back to it in a moment. Most patients with hypertrophic cardiomyopathy have an abnormal ECG. Typical ECG features include left ventricular hypertrophy with a strain pattern, prominent Q waves in the inferior and lateral leads, P wave abnormalities like left atrial enlargement or biatrial enlargement, left axis deviation, and deeply inverted T waves, which are sometimes called giant negative T waves, which are often in the precordial leads. You can see in this patient with hypertrophic cardiomyopathy that he meets the left ventricular hypertrophy criteria with a strain pattern, but he's missing prominent Q waves in the inferior and lateral leads, and he's also missing a left axis deviation. But he shows the classic deeply inverted T waves or giant negative T waves in his precordial leads. And these are characteristic of a patient with hypertrophic cardiomyopathy. Last, we'll talk about the Wolff-Parkinson-White Syndrome, or WPW. It's relatively common. It affects about 1 in 500 people. These patients have an accessory atrioventricular pathway outside of the AV node, and this extranodal pathway usually lacks decremental conduction. Sudden cardiac death in these patients is most often due to atrial fibrillation that conducts rapidly to the ventricles over the accessory pathway, and that leads to ventricular fibrillation. However, the risk of sudden cardiac death is relatively low, and it's estimated to occur in only about 1 in 1,000 patients with a WPW ECG pattern. The patients who are at high risk for sudden cardiac death can conduct usually faster than 250 milliseconds. However, most patients can conduct even faster than that, and the patient that I've shown you here has an R-to-R interval of about 160 milliseconds. This is the same patient after cardioversion, and you can see the characteristic short PR interval now that he's in sinus, and you can see the delta waves that are consistent with the left lateral accessory pathway. Ablating the accessory pathway reduces the patient's risk of sudden cardiac death back to normal. To summarize, unfortunately, we're still not very good at identifying patients who are at risk for sudden cardiac death. However, the ECG is one of many tools that we can use to help us identify those who are at risk for sudden cardiac death. Certain ECG patterns, like the ones we went through today, can be learned so that one can recognize patients who are at risk of sudden cardiac death. but any single test, including the ECG, is often inadequate to risk stratify a patient. Here I've listed two selected references that I used to help prepare this talk. The first is a review article called Surface Electrocardiogram Predictors of Sudden Cardiac Arrest, published in 2016, and the second are various chapters from Cardiac Arrhythmias, Interpretation, Diagnosis, and Treatment by Prstowski, Klein, and Daubert, published in 2020. Thanks for sticking around to listen to this talk. I'm sorry that I went over time.